This podcast is for educational purposes only. Please consult your doctor before changing any medical care. This information, products, or comments contained within this podcast is not approved by the FDA for the treatment or diagnosis of any disease. Although we attempt to keep the information up to date and current, we cannot guarantee the information is up to date at the time of this recording. Individual results will vary. No one should expect the outcomes or results mentioned or described in this podcast. Health shares do not constitute health insurance and do not provide a guarantee to pay for your medical bills. Please consult your broker, general counsel, and/or doctor before changing your healthcare plan. Envita and Envita Health makes no guarantees for outcomes and results. Thank you for joining us. I'm Dr. Dino Prato, founder and CEO of Envita Medical Centers. I'm here with one of our chief medical directors that works also in R&D, Dr. John Oertle. John, thank you for joining me today as we go over another case history. This is an exciting case history. This is a late stage, you'll see here in a minute, the pictures are worth 1,000 words, of a very late stage breast cancer. And it shows why, John, as we go over this, Dr. Oertle, the importance of precision oncology, right? As we're working with these patients, precision oncology, our medical team is working on it. And I work on the R&D side. But as we're working on developing these algorithms over the years with our technology, the proof is in the outcomes. And this is what we want to share. So, John, let's go ahead. I'll let you go ahead and introduce the case, and I'll move us through, and I'll ask questions as we go through and kind of point things out for those people who are listening.
Excellent, Dino. Yeah, this was a patient that came through just only a couple of months ago, and we've got an amazing team that follows these algorithms and is able to give this great care to these patients. But this was a 70-year-old female with stage 4 breast cancer. And she had failed all their treatment modalities, as we'll see and go through the actual case. But she came out to Envita, and she had an initial diagnosis of estrogen receptor positive, progesterone receptor positive. HER2 was both positive and negative. And as the disease had continued to be able to progress and had continued in her life, she had both presentations of both negative and positive. We'll talk a little about that in this case because it's a very interesting thing as far as why it's important to be able to do the kind of algorithms and the testing and the evaluation because of the way cancer moves and responds as you continue to be able to go through the course of treatment. But
John, let me ask.
This was a case that was breast cancer, but the cancer was littered everywhere in the body, specifically all throughout the bones.
So let me ask you a question. How common is it for us to see these late-stage cancer patients who've already failed standard oncology at well-known facilities and have tried 1, 2, 3 different rounds? How common is it for us to see these patients? And then, as we showed in our 2020, at least internal data, 90% of them were on the wrong drug treatments.
Yeah. So well, first of all, your question as far as how frequently do we see these cases? We see them all the time. So Envita has become specialists in the actual late stage, difficult to treat cancer patients who have failed standard of care, who are looking for options, and they know there's something better, but they can't find it at their local facilities. And so we see these patients all the time, and we've become the experts at late stage cancer treatments, not just breast cancer, but all the actual cancers. When there's a precision always gets better outcomes, especially when it's late stage. Now, in the early stages, we take early stages as well, but we also see that those are easy to treat and those don't require as much advanced technology in order to be able to actually achieve the kind of dramatic outcomes that we actually see.
Well, and I think as we go through this case, I want also to point out, we'll get as we go through later, about how had we have seen this patient even earlier, she could have avoided, right, all the widespread disease because of the way that we monitor metastases or the spread of cancer before it happens using circulating tumor cells, CT-free DNA, and some of our algorithms that look at prediction of prognosis.
That's right. Okay, well, let's move on to the next slide.
Okay, go ahead.
All right, so like I said, this is 70-year-old female. And let me just say too, 70-year-old, we see older patients all the time. 70-year-old is not old, even though in conventional oncology, sometimes they get concerned because the older you are, the more weakened immune systems you have, the more difficulty to be able to tolerate high-dose conventional chemotherapies. And so this is where we see with that precision approach, we're looking at genetics, we're looking at age, we're looking at other toxicities to be able to match and make sure that the actual patient is receiving it incredibly well. So again, age is not a factor either.
Well, and let me just add this. This is my clinical, from years of being around in the setting, some areas, particularly countries that practice socialized medicine, they tend to select the patients, based on their age and other things. They don't talk about this, but on who gets to get treatment or wait or be on some waiting list, which I think is crazy because everybody deserves the opportunity to live. So I'll let you continue, but we do see patients that are older, and they do, I think, with these gentler approaches where we're getting less side effects, less of these aggressive chemo, more immunotherapy targeting, they just have a better quality of life throughout care as well. So I'll let you continue. Let's keep moving.
Yeah, so she was originally diagnosed with an estrogen receptor positive, progesterone receptor positive, and HER2 positive breast cancer but she hadn't developed any osseous metastases or bone cancer, metastatic disease to the bone yet. But what she had in 2020 is she had a double mastectomy. So she had originally seen a localized cancer in the actual breast tissue, and she went through a full double mastectomy, meaning removing of both breast tissue. And yet, what you see here is that in 2 short years, the cancer returned and spread all to the actual lungs and to the actual bones. And
so let me add before you go further here. This is much more common than patients understand.
That's correct.
So just to put this in a simple way where everybody can see this particular breast cancer was sensitive to hormones. You see here, it has estrogen, progesterone, HER2, right, which is a target for a particular drug. But in this messaging, we see the patient gets this double mastectomy. The idea was you get rid of the cancer, you have that remission celebration party, I'm cancer-free, 2 years later it returns. This can happen in breast cancer very commonly. And the sad thing is, had they done the right testing back when in 2020, when they first started doing this elimination of the tumors, they could have already potentially seen data showing that the cancer was spreading, and not to remove the tumor from the breast, but in fact, begin with immunotherapy at the local breast, create an immune system response to shut the cancer down. And then if we would have seen this in 2020, 2022, we wouldn't have surgically removed it. We just freeze the tumor and be done. It'd be a 45-minute procedure. We'd have tracked the genetics in the blood. It's where cancer is going, I keep saying. It's not there yet. And it would have changed the trajectory significantly for them even to do other care.
And Dr. Prato, there's no testing early on of carcinogens and what could have potentially led to the actual cancer. There's no testing of biomarkers as far as the signaling to that actual breast tissue. And there's no testing to be able to see what systemic or what treatments can you actually give to be able to support health, not to mention you're talking about immunotherapy. So there's all this miss, and this is where when you actually run the early disease, you can actually run that to be able to actually evaluate, to be able to make sure the patient has the best likelihood of shutting it down and never having it return, even though one of the tests that we run is called circulating tumor cells. Here you go. So you'll see it on the actual slide here.
And so she had a
return. So you could have run that test at the very beginning and being able to see, do you have, when you say circulating tumor cell, this is a cancer cell. It originated from the breast tissue where the original cancer was at, and it breaks off, usually goes to the lymph nodes, and then it eventually makes its way into the bloodstream to be able to get into the bone and the lung. You can run that initially to see, are you able to identify any cancer cells that are broken away from the primary lesion and been able to actually already have evidence of spread. And I can almost, with certainty, tell you that time that she had the double mastectomy, she had already had evidence of the cancer had spread from the tissue and was already spreading around in the actual body, but it was never tested for, it was never diagnosed.
And see, you can even see here that she had already radiation therapy to the thoracic spine, or up in the upper area there, the thoracic area of the spine, around the lungs. That when this disease is spreading to the lungs and to the bones, it's advanced. It's an advanced cancer. It is no, in the standard model, these are much more advanced diseases, more difficult to treat. So let's move on. So she had radiation.
So she did get radiation this was when it had returned and it had already spread everywhere. She got radiation. And I think that may have been a good reason to get radiation because of the fact that, again, with that T8 lesion and it it can fracture. One of the biggest risks to bone cancers or bone metastatic diseases that you can have risk of fracture. We do this a little bit different. We have different treatments, but radiation can be an effective way to prevent
particularly in the femur. That could be life-threatening. Femur
That's
fractures is a
But
big deal. So that's another reason to treat that.
But as soon as she saw that she got the radiation, but she declined any systemic treatments because she realized at 70 years old that high-dose chemotherapeutic regimen that they wanted to be able to put her on probably would cause more harm than good. And she decided to be able to elect to not choose to go that route because of the fact that she didn't. I firmly agree that she doesn't want to endure the side effects of that high systemic dose chemotherapy. And I respect her decisions and her choices to be able to choose the therapies that she wants that's best for her values.
Well, and if you're talking here to just a standard conventional oncology group, they'd be like, oh, that's a standard of care. That's what we're going to do. And this person would not be alive today. Let's show you what Envita was able to do.
72. Well, she had 72 circulating tumor cells per 7.5 milliliters of whole blood, meaning, again, this is a very high level of, she has a high burden. She also, in those CTCs, those circulating tumor cells, one of the misnomers too, so she had a HER2 negative upon first being diagnosed with the tissue test. That's a tissue marker. That's one of the less than 20% precision modalities that patients receive. HER2 positivity is actually in that category. She didn't have HER2 positive, and we were able to identify that she did have HER2 positive, but it wasn't on the tissue. It was on the circulating tumor cell.
Well, let me explain that because I think the general public. So when they try to look for this, they do a biopsy, right? Originally, they look at the tumor's biopsy and they say, well, is this estrogen positive? Is estrogen making it grow? Is it progesterone positive? Does it have a marker for Herceptin, which is a very important drug in breast cancer if it's there? In essence, if you just looked at the original biopsy, right, you're starting to see the data telling you different, saying it's negative. But then when you actually do our genetic deeper testing of taking it just from a normal blood draw, but looking for the cancer cells that are separated from your normal circulation, and then running all that genetic information on circulating tumor cells, now you get different information. And you're starting to go, wait a minute, this cancer is Herceptin positive, meaning it is a target, but originally it was diagnosed as Herceptin negative. So this is critically important because if you miss this, you could miss the entire chance of really making this a manageable and much more treatable, higher quality of life for the patient. I can't express this enough. You will hear over and over again, oh, this is not standard of care. This is considered experimental. No, this is good medicine, good science. The more information you have, the better chance you have of saving somebody's life. And every person deserves that. Every patient deserves more information to guide their care, not less. So let's continue because
more data is in the world of cancer. More data is better to be able to make life-altering decisions on. And this is where when you actually are treating with cancer, it's not just more data initially. It's consecutively because cancer is a growing, mutating, moving target. And so this is also why it's not just a single splice of good data initially, but it is good data, good data, good data, good data to be able to actually drive and move to ensure that the actual outcomes and response is occurring. And then it continues to occur. And then you're continually able to keep treating effectively because as that mutates, you don't want it to be able to mutate. And then again, treatment becomes non-effective, or then you start to be able to see it getting out of hand.
And it's important that the medical facility knows what to do with the data. That's a whole nother conversation. Like you can have all the right data in your face, but 9 out of 10 of these guys are just going to say, well, I can't do this. It's not in the textbook. It's not in it. But nobody's a textbook, especially when you understand the heterogeneity or the uniqueness of everyone's cancer. Everyone's cancer, like a fingerprint, is different, like a snowflake, as you've said before, and it requires targeting. So here we're looking at
So
Tumor mark.
these are tumor markers. These are classical tumor markers that frequently are run in breast cancer. CA2729 is frequently run in breast cancer, very, very high. CA15-3 commonly run in breast cancer, very high. CEA, not so much seen in breast cancer, but can be elevated in breast cancer. But this is one of those areas we like more data versus less, so we run that as well with our patients. And we saw that this was another high elevation. You can keep going on, but this was when she originally came. Here's a snapshot of when we actually are seeing her, some of the actual, this is just a snapshot of some of the actual biomarkers of the other testing that we looked at. She did have what's called a PIK3CA mutation. She had a TP53 mutation. And so again, TP53, very, very common in cancers. Again, many times you'll see this kind of in the literature in only select cancers, like cervical cancer, for instance. But it is in almost, again, I've seen this almost in every cancer type. And it is a very common, it doesn't mean that it is in every cancer type, but it's very commonly found within cancers.
So how common is it for patients to get these genetic tests that look for mutations and variants? Because cancer is a disease of mutations. How common is it for patients to have these types of tests?
Very infrequent. Very infrequent.
Why?
Well, because sometimes it's not covered by insurance. And what's really interesting is that, thank goodness, even in the state of Arizona, and we work on the political side and work with our legislators here in the state of Arizona, we were able to get an actual law turned to be able to actually require insurance companies to be able to provide genetic testing for cancer patients. Very, very good as far as a win for patient rights and for the ability to be able to actually have this data. But many times oncologists are unwilling to be able to have it because, one, either insurance is going to cover it, but even if insurance does cover it, that it creates a conflict with them because you have data suggesting that the actual treatment that they're going to be on or the chemo that they're going to recommend is not going to be effective. And then it's showing that there's treatment that's out there that may not be on standard of care or insurable, or what the insurance company is going to cover for their chemotherapy regimen or what they are going to prescribe, but it's actually shown to be beneficial for them.
So is it fair?
A conundrum for them in this context. And so oftentimes oncologists just say, don't run that. Don't even worry about it. Because what are you going to do when your hands are tied behind your back as an oncologist if you're just getting information? And what then, I've heard this talked about as far as false hope, then it's almost, that's where they don't want to give you false hope, because they're saying, well, let me run this test and then I'm going to dangle this carrot out in front of you and yet never actually be able to even give you that therapy because the institution doesn't allow for it or the insurance doesn't actually cover it. Does that make sense?
Yeah, so let me ask you another question, and I kind of know the answer to this, but is it fair to say that what insurance you have, even if you think you have the greatest insurance because you have a low deductible, right? You might have a low deductible. You really don't have access to the best technology in the world. You get access to whatever your insurance covers. And is it fair to say that based on your insurance, in fact may limit your ability to get well and may accelerate your progression of disease, death, and morbidity?
Correct.
Because you don't have the ability to use the latest technologies to help you live and improve your quality of life?
Yeah, I've heard it said many times that patients thought that they had great insurance, and then they came to use their insurance and it didn't cover anything that was actually needed when you actually needed it most, specifically the technology to be able to treat very difficult diseases. And I will share this, is that many times people say that they have the best insurance. Why do they say that? Because you're right. They're paying an arm and a leg for it every month. So they think that it's good because they're paying a huge amount for it. And then they also think it's good insurance because it's a low deductible, or there's a low out-of-pocket maximum that they actually need to be able to pay to be able to get the insurance to cover the care. But what if the insurance doesn't cover the care that's actually the best for you to be able to achieve your results? Then I don't care how low the deductible is. I don't care if you're able to see the best centers. If it doesn't cover the kind of care that you need to be able to see when your life most depends on it, it's not good insurance.
So here we are looking at these mutations, right? We got this common P53, right, which is a pathway of, and let's take a look here. The next picture is the imaging.
Okay, so
Before you
here, this
start
is a picture says 1,000 words, right? And so what you'll see here, this is a PET scan image, and a PET scan is where the cancer cells are taking up a glucose molecule, so it lights up like a Christmas tree everywhere the cancer is at. Again, another reason why I can't believe that oncologists say that it doesn't matter what you eat or that sugar doesn't drive cancer, because a PET scan is a clear definition of that this is sugar that what you're seeing here in this image is that the cancer cell is taking up sugar to be able to identify where the cancer is at.
Because this is after the mastectomies. So the breast tumors were removed. This is all the spread because of that cancer is moving. And you could see it all on the leg there to the right of what you're seeing. You can see all that in the bone. I mean, that's very aggressive.
All of the black,
all the bone, all through the body, everywhere these dots are, you're seeing this is cancer growing and metabolically active.
Yeah, and all that big black blob that's down on the lower part of the body in the center, that's the bladder. So that's not cancer, but everywhere else that you're seeing is identifiable in cancer, in the lungs, in the bones, and in the lymph nodes.
Yeah, let's move on. But this image is what we started with. This is what our team started with at Envita. So you can see what's about to happen when you get good technology in place for this particular patient. So,
okay, so
this is what the imaging was showing.
That's what the radiologist read the report.
Yeah. This was the report showing you the image we just saw before, where this is the mass, bilateral, pulmonary, multi, and the bones and the liver. I mean, when a radiologist sees this, they're like, this is a hospice patient, right? Or something of that extreme. This is a very late stage cancer patient. They're like, this is done, take a cruise, whatever that is. This is a very late stage cancer patient. But that's because, they may not typically see what good targeting does. Now, this is the treatment plan.
Okay, so here, this is the treatment plan. We prescribed a 12-week treatment plan. We gave her the genetically targeted fractionated chemotherapy with our algorithms. That's where the GTFC, or genetically targeted fractionated chemotherapy. We utilize our algorithms because it's based upon this 23 years of continually being able to ensure that we're following the patient's individualized care plan to be able to ensure that there's the best treatment possible.
I got this question the other day about, well, what is this algorithm, right? Because it's, the special thing. Well, we use, not to complicate it, but we use transcriptomics, which is a type of genetic testing. We use genomics, which is the genetic part of the testing. And then we use immune profiling. And when you look at that, our data, even from our 2020 internal data, 90% of the patients, after we run those tests and we look at the way our experience tells us to treat the patient, 90% were on the wrong treatments, in our opinion, coming in from other facilities. Now, to get our doctors to be able to even kind of work in that algorithm, it takes about 1 year and 1,500 hours of training, right? And John, because for years, Dr. Oertle and I know the work that goes into that. For a doctor to understand when they run all these details, all these genetic tests, all this information, putting it all together so that you can have the best targeting. Now, I want to leave it with that because when people say, what is that algorithm? Transcriptomics, genomics, immune profiling, individualized for each patient, you're about to see what that outcome looks like, which is very good. But then immunotherapy, which you can argue that outside of PD-1 inhibitors, what's immunotherapy in conventional oncology? What is it? Outside of variations of these PD-1 inhibitors, we have so many different reiterations of that, to the point where we even build cellular therapies that we started in the early 2000s, where we have such a breadth of experience in the immunotherapy world. These things can make a big difference. I'll let you continue, Dr. Oertle, as you're going through this, but I just want to help people understand there's so much. It makes all the difference what treatments are selected.
Yeah,
that makes all the difference.
And even with immunotherapies, PD-1s can be great when you have biomarkers to it, but we've seen many patients where they fail the PD-1s, and then we can actually turn them on to be able to be responsive again. So this is all where we have Wait a minute. Dr. Oertle, you are saying something to the medical community here. You mean you can improve the PD-1 expression
in a natural killer cell? Is that, you mean just taking a sample of a circulating tumor cell and seeing whether it's PD-L1 or PD-1 positive is not enough? Of course. So what we're saying is that even the usage of these immunotherapies we've been using them since 2015. We're very familiar with their mechanisms. They're in their infancies because, whether you have microsatellite instability that's high or whether you have a marker, there's many other components that go into these cancers. And frankly, they're okay. They're not as great as everybody thinks they are, because what people don't know is the spatial omics of how much of those PD-1 and PD-L1s are actually in the individual tumors. So even after you give a PD-1, you may only have 10% expression of the tumor. It might work on 10% of the cancer. It doesn't eliminate it, right? Because our goal is elimination. It's an important thing to understand the limitations of when people say, oh, we did immunotherapy at this or that cancer center. It's behind. It's at least a decade behind where immunotherapy is going. And so here, the patient does an immunotherapy NTC, which is a strong natural killer cell immune boosting integrative care process, right, with this patient.
Great. And then we also delivered CIPI. That stands for chemoimmuno precision injections, where we're able to actually go directly to the actual spot of the tumor, oftentimes with the catheters the size of your hair, directly to the spot of the actual tumor, where we actually are injecting it with the chemotherapeutics. We also inject adjuvants along with the chemotherapy to be able to enhance the chemotherapeutic action and the immunotherapy within the body. It doesn't just treat those lesions, as you will see. This is where we injected the right and left subpectoral and axillary lymph nodes. We only injected some of these cancer lesions that you saw in the image back a couple of slides ago. But what you'll see is that when you perform these CIPI injections, the chemoimmuno precision injections, we look at lesions that are going to be the most effective to be able to, and the easiest to be able to access through these injections. But what it does is that it helps to be able to build an immunotherapy response where the immune system no longer allows the cancer to be able to be residing as a friendly cell, but it creates it and recognizes it and tags it to actually be an enemy. And
so it awakens the immune system to kill the cancer. So here in this image, as the patient first came in before we did treatment, only 2 areas were injected, a couple areas. And yet you're going to see how it works throughout the entire body, because once the immune system knows what's going on, for many times it can be game over for the cancer. At least they get a different picture.
That's right.
That's a very important aspect here. So
then we also did some off-label use medications, some on-label use medications for the precision targets. We also used some adjuvant medications, IV therapies, to be able to help support the actual healing and health of the body. Let us not forget that when we're treating a cancer patient, they're more than just cancer. We also want to be able to make sure that everything is being helped and supported and their system is being supported as well. So, and then because you're going to be strengthened and the prognosis is better when the patient is having proper nutrients and proper support.
Let's go on. And what you're going to see here, and I think you'll go over this, is why you need to look at multiple laboratory data points, and you can't just look at one, which is very important when you're tracking a patient.
I love this case for this reason. Okay, so these are the tumor markers. Like I said, conventionally, you're going to see the line that has the circles on it is the CA2729, which is a conventionally standard tumor marker run in breast cancer. The little square is 15-3. That's, again, what's conventionally run in breast cancer. The triangle is the CEA. That's another conventionally ran tumor marker, less likely in breast cancer, but here it was still elevated in this patient. Okay, what you see is that this is oftentimes when blood work is being performed, this is the blood work that is being ran in the conventional oncology offices for breast cancer. Okay, so what you see here is, I always say, these tumor markers are what's called a lagging indicator. So by the time that the patient came into Envita, they were sky high. And what you can see here is that they're continually sky high. Now, why is this? Again, it lags. Why? Because when you have a lot of cancer, the CA stands for cancer antigen. This is a little marker on the surface of the cancer cell. When you're killing cancer, you can see these little markers sloughing off into the body, into the actual bloodstream. So oftentimes you can see that it doesn't actually shift, it doesn't change. Sometimes you can actually see it actually elevates as well. But in this case, it just stayed static. Now, if you're just running this, you would say, and all you had to go on as a patient or as a doctor who was treating a patient, I would say, I do not think the therapy is working. It's holding it stable, but I don't think it's doing anything for you. And you may want to consider changing the therapy, or you may want to stay on it, but it's holding it stable. It's not doing anything to be able to treat. And what you'll see is that I hope that you can actually identify that when you run further, deeper testing and evaluation, that it actually tells you deeper what's actually happening.
So here you're looking at the genetics, which is telling you a different story. The genes are showing you that the cancer is slowing down, right? You see a drop.
So this is cancer cell DNA. And what this is showing you is that the DNA is at the beginning was elevated, and you'll see it was elevated in January, and it rose a little bit in March, but then it was no longer detectable at the end of care. It had completely shut down. What does this mean is that the cancer no longer is presenting. There's no longer ever any evidence that there's any cancer DNA floating around in the bloodstream in this patient. This is very sensitive, and this is also very good prognosis. The evidence, the data, the peer-reviewed articles on CT-free DNA and prognosis are very positive. That when this
it's a leading indicator,
and it's able to see it at the same time that you're seeing this dropping. Is at the same time it drops before those tumor markers had ever dropped in this case.
So let's look here at the bottom line, which is the before and after.
And now the proof is in the pudding when it comes to the image speaks 1,000 words. This is the same kind of imaging of a PET scan that was performed at the beginning of care and at the end of care. And what you can see here is that this is absolutely, the treatment is responding. What you'll see, look at that. The patient, there still is some residual disease. The patient is not completely clear. There still is a little bit of areas where there's less aggressive cancer. But what you're seeing is that cancer, it is just completely responded to care. And this is one of these areas where the immune system, this case will continue to be able to respond to this care. But it's just a beautiful thing. And this woman,
I mean, you're looking at you're less than 2.5 months. Look at the change in this patient. I mean, that's dramatic, right? From February 8th to May 5th, you can clearly see. So here we have a breast cancer patient who had both side lumpectomies or mastectomies to remove the tumors. The cancer returns 2 years later, which is very common, more than people think. We see it in 20-30% of patients. They do some radiation at home. They're concerned the disease is widespread to the bones. It's widespread to the lungs, all through the bodies we can see here on the left. She comes into Envita. We do precision targeting, which is very different than conventional. We target, we treat with precision. And here you have in May 5th, look at already the trajectory, the change in care in 2 months, the before and after. This is a late stage breast cancer. Had we seen the patient sooner, we would have never gotten this far. We would have been able to literally do it early because we have the genetic testing and the circulating tumor cell data that would have told us the cancer spreading, and we would have treated it appropriately with the immune system and the right targets right from the get-go. But since this patient was progressing in the conventional model, they weren't using genetic targeting. They weren't using advanced immunotherapy. They were kind of stuck with NCCN guidelines and whatever insurance covers, which has huge limitations. And so this is why we really say everybody deserves precision targeting. You can see the difference here is great. Anything you want to add, John? Dr. Oertle?
No, the only other thing I want to add is that this patient is still continuing to remain in our care, but she is not. So with Envita, we bring patients in, we treat them, and then there's home support. This patient is continually flying back out to be able to receive this ongoing care so that we're able to continue to keep tracking and following, because at home,
what's her quality of life?
Her quality of life is phenomenal. She's happy, healthy, and she is doing great.
So we've taken a disease, by the grace of God, that was terminal, right, and made it manageable and continuing to slowly improve and stabilize, because the patient can now live their life with better with really, to them, really not knowing they have cancer at this point, because most of this is cleaning up in their body.
That's right.
Yeah, this is a blessing. Well, listen, thank you for joining us. Thank you, Dr. Oertle, for sharing this case with the team. I just want to welcome all of you who are watching. If you have questions, to reach out. We have people that can help answer your questions. But I want to ask the Lord to bless all of you on your journey to healing. We're here to help you in any way that we can. We're just excited to share these stories. We'll continue to be a voice for people who need options and deserve options. We'll continue to be a voice for healthcare freedom, where people deserve and their dignity of life to live. We're here to fight for them. We believe that, as we've shown in our 23 years experience, there's a lot you can do with when you have the right information. And so we want to give you encouragement and real hope from the real patients that we treat at Envita. Nothing speaks like our patients. Nothing speaks like the before and afters. No matter what we say, when you see this in a late stage cancer patient, no matter who you are, in oncology, whatever industry you work in, you go, wow, there's something going on there. So I want to thank you all for joining us. May the Lord bless you on your journey to healing, and feel free to reach out with any questions you might have. Dr. Oertle, again, thank you for joining us.